This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Conception, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
DPC to me is a win for the whole world. It's a win for the patients. It's a win for the doctors. And it's a win for self-care. You can be a great doctor and actually a balanced, great human at the same time. I am Dr. Lisa Davidson of Insight Primary Care, and this is my DPC story.
Dr. Lisa Davidson has been practicing family medicine in Denver since 1997. She completed her residency at the University of Colorado Family Medicine Residency at Rose Hospital. Dr. Davidson serves as an assistant clinical professor at the University of Colorado Denver School of Medicine. She is a huge advocate for the direct primary care movement, and after running a traditional practice for 8 years, she made the leap to open Insight Primary Care, a DPC in Denver, Colorado in 2012. She speaks nationally on direct care and enjoys mentoring other doctors who are interested in converting to the DPC model. In her spare time, Dr. Davidson enjoys travel and is always seeking new adventures with her husband and 2 children. Welcome to the podcast, Dr. Davidson.
Thank you. I'm staring at your face in the park on my phone, but I'm also looking at you in the park on my phone.
This is legit what happens when I've been podcasting for, over a year on Zoom, and then now I'm not sure how to do this in real life time. So yes, it's interesting to see you and see you in 2 different places. And this is crazy because it's in your place of work where your DPC is in Denver. And it's so exciting because you and I met back in 2019 at the HINT Summit in San Francisco. And I literally have, just loved your journey because you are a mom and you are doing DPC when you want to do DPC, and that is not a full-time job. So I love, love, love that. So thank you so much for coming on.
I have to tell you, not like I know it sounds like I'm complimenting the host, but I am, because I remember when I met you, I could meet people and within 2 minutes, say, yeah, they'll do well, or very low, or very few people. Amber is one also. And so is Bree. They're going to take this thing so far. I can't even believe it. And she's just this smiley little 2019 girl. And now look at you. Okay. Anyway, I had to say that.
You're so sweet. You're so sweet. But, it's amazing to see you speaking at the first HINT Summit years ago, and to see where this movement has gone. It's incredible. And you're a testament to how, when we work together and we help each other along the way, how we can make this movement really different than anything we've ever seen before. So it's awesome. So I want to start with that. You've spoken about taking the leap into DPC, but I want to actually just point out that you have taken the leap twice. You went from residency into an employed position, and then you left your employed position to open up your own private practice. So how did you even have the courage to make that first jump going into a private practice when the trend at the time that you left your employed position was to be employed.
Exactly. I remember a couple of things from my residency director who was very wise. And he said, when you guys graduate, you're probably going to stay at your first job for a couple of years, and then you're going to go somewhere else. And I had accepted a job with these amazing women out of residency. And I thought, like, that's stupid. Why would he say that? I love these women. I'm going to work with them forever. And so I went to work with them, and I lasted about 4 years, so twice as long. But at year 3, they were barely making it, and they were private practice. But I was looking at it and I'm like, these women are amazing doctors, but they don't know about business. And so I don't feel like they're ever going to survive. Like, they're wonderful women, but how are you not making enough money to survive? And of course, it was also part of those times in the industry and people were getting bought up. So I was naive or stupid or crazy. And I just said, well, I think I can do this better. So I'm just going to, for fun, try. Why not? So I worked for like a year researching how to do it. And I didn't want to have an office manager. I just wanted to do it myself. And so my dad was an accounting teacher and an accountant. So I thought, well, I must have some genes for accounting. So I think I can do math. So let me just try to get my insurance contracts. I had a wonderful biller. I had an amazing PA who I still have. I had an amazing nurse. I had an amazing front desk person. So I thought, well, let's go. Let's do it. Let's bring some of these people over. And the front desk didn't come, which was sad because I loved her, but that was one of my fun staffing issues for the first few years in fee-for-service practice. But we found a space, and my husband is an awesome architect, and he built out the space for me, and we just opened, and it happened.
That's incredible. And, especially for those people who are thinking of opening after residency, there are people out there who are considering, well, maybe I'll open fee for service first and then, potentially move into DPC. So if you had the choice, would you have chosen to do DPC, given that at the time it was still such a new, it's not a new model, but it was a new model?
Yeah. So would I have done it differently back then? Like, no way, because it was back then. Would I do it now, fresh out of residency? I love the people that do. And I think you're all amazing. Would I have had the courage? I don't think I would have had the courage that you guys had, only from the clinical aspect, because I feel like I needed to see 20 patients a day for a few years. But we have so much support now in the DPC community that I think it makes sense to go straight out of residency and do DPC now because we have that support. In 2008 or 4, no way. But now, yeah, I probably would have.
It's so good to hear somebody who has been in practice for so many years really be able to reflect on both of those times, like the time we're in now and then the time that you left your fee-for-service job as an employed physician to open fee-for-service back when you did. So now when you were talking about the insurance contracts and whatnot, and you were realizing that the business of medicine really matters when you're in private practice, whether you're in DPC or fee-for-service, how did you really start to understand your business when you were in fee-for-service to make your office efficient and profitable?
The secret for everybody in DPC, anywhere, you surround yourself with people who know what they're doing. Like, I had a really good CPA. My biller was phenomenal. Like, I couldn't have done it if I thought I was smart enough to do it all by myself back then. And so I respect people who know what they're doing. And in family medicine, we're good at that because we respect our specialists because they know more than we do about certain things. So I listened to them and I learned from them. And sadly, we were a very popular practice. We were busy, but I didn't pay myself a lot of the time. I just skipped my paycheck. And it was the classic story of a new mom sitting on the couch with the baby next to him, doing my charting at 9:00 at night. So it was profitable to a point. I don't think I broke 6 figures while I was in private practice for 8 years trying to make it work with insurance. And I worked 3 times as hard as I do now.
That's so ironic, but it's so insightful to hear you say these things because you've really lived, a decent time in fee-for-service as well as now in DPC. So I want to ask about your courage and your jump to leave your fee-for-service private practice to go into your own DPC. Yeah. How was the courage and that jump different than when you had made the jump into your own private practice previously?
Oh, that's a good question. I was 12 years in fee-for-service, totally exhausted, 2 little kids, fantastic husband who was so patient with me, working to the bone, not making enough to pay off my student loans. And so I was either going to like quit medicine or go work at Kaiser and be miserable, or I don't know. So I was like, there has to be something else. So I was out of desperation. And then my dad had died in 2009, and that made me start thinking about the world. And then my mom passed away in 2012. And those both just woke me up, because they had 4 kids they saved for their whole lives to put us through school, to make sure we're successful. They always put off their life. They're like, we'll do it later. We'll do it later. We'll do it later. So they both died, like barely being able to travel the world like they wanted to. Like that was always their dream. And so I thought, like, I'm not going to do that. I'm not going to honor them by working myself to the bone my whole life and then saving and saving and saving and then dying. Like, that's not how I'm going to honor my parents. The passion behind my change was what gave me the courage to do it. And everybody in DPC has a passion story, I bet you.
I would definitely agree with that for sure. And, it's so funny. I remember that the person who had told me about DPC was actually Dr. Ariana Demers. She's an orthopedic surgeon. But I remember she posted one day, I think on the DPC Docs page, what was your last straw? And it was like, well, there goes the, kerosene on the fire. And then you had 127 posts within a few hours, because that's how everybody has had their passion come from a particular spot, whether that's because of not being valued in the system, whether it's they aren't valuing themselves, whatever it is. And I love that you're honoring your parents is a part of your story. I think that's so awesome.
Yeah. And that's the part I love about hearing, like, you and I we're exchanging stories of how we met our husbands, but like hearing people's, what was your passion moment? And everyone has one.
Yeah, it's so good. It's so good. So now when you took this passion and you wanted to mold it into something that possibly was medicine versus leaving medicine, you had mentioned that you learned about Pam Weibel as well as reading Dave Chase's articles. And Pam Weibel, for those of you who are not familiar, is the creator of the Ideal Medical Practice, or IMP. And then Dave Chase is one of the co-founders of Health Rosetta. And so when you were reading and learning from those two individuals in particular, how did you start thinking about your DPC in terms of, did you start dreaming or actively planning, or both at that time?
What a great question. So I think of Pam as the heart and Dave as the brain in my DPC baby. So Pam inspired like that heart in me and looking at Ideal Medical Practice. And I was like, that's amazing. I love it. The connection with your patients, blah, blah, blah. And then Dave, I was like, okay, but what about the nuts and bolts? And so Dave was like, I read this really, really old article from a long time ago. And he used like, what is that? I love that phrase, innovative disruptor. So it like stuck with me. And Pam too. And then this popped into my head, this idea popped in my head, is like, I need to shrink in order to grow. And I think I meant I need to shrink my practice in order to grow as a physician. And so I used both like the heart and the brain of the DPC ideals back then, along with Garrison and Erica, and blended those together. So I woke up at 4 a.m. one night and went to my kitchen table, and then I started the planning part.
And when you were going forward and learning more about DPC, and you were finding individuals that were actively doing this idea of direct primary care in live time, in addition to, Q-Liance, in addition to what Dave Chase was talking about, you had found people like Ryan Newhoffel and Sharon George. When you were planning, when you said you whipped out that paper at 4 o'clock in the morning and you started planning, how did that change your plan or your ideal practice for your future?
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes.
Oh, that's a great question. Yeah, I liked the IMP idea, the ideal medical practice idea, but obviously I'm way too social to be working like alone in a clinic. So I was like, I need to have I love my staff too. I don't want to be alone. And then I think I found Ryan and I called Ryan and was like, what are you doing? And he's this young guy and he's telling me all about it. And I thought he was really brilliant. And it was so funny because you could call and like Sharon, you can call people back then, like the 20 people that you could find on Google that were doing it and talk to them all. And one of the things that struck me today, I was reviewing like who all you've interviewed in your podcast. And I was like, oh yeah, I know that name. I know that name. I know that name. And then there were like a ton more. I'm like, I don't know that person. I don't know who that person is. And I thought, this is amazing. Like, I don't know most of the people in DPC, that's great. Like, that means it's too big to know everybody. It's so exciting.
When you talk about calling people, like calling Ryan and calling Sharon was in practice in Irvine, the Renaissance DPC. She had, a micro practice in terms of she was doing it out of her home, like Neil Douglas style nowadays. And so when you saw that, like what did you pull from her practice, similar to how you did when you were talking with Ryan, that you built or did not build into your practice at Insight?
I don't know if it was specifics the way I built, but it was just like the feeling of who they were and their personalities. And they were very, they could draw you in very naturally and they're very comfortable to talk to. And they were comfortable with their model and they recognized that it was really, really brave and they were pioneers and the bravery in them is what just sort of struck me. And I think that today, that's why people always say, go to DPC summits in person, because we always joke that it's like a cult, but it is, because the energy that is at those meetings is ridiculous. And it gives you the bravery that you need to do it. Like it really does still.
So now I want to ask something that is very different for you, because you were going from your own practice into your own DPC. What were some of the things that you realized that you did not need, that you may have needed in fee for service, but not for DPC?
Oh, the hardest one was I didn't need my biller anymore. And I absolutely loved her. And so I was trying to figure out a way to bring her with me and there was just no feasible way. And she was such a good biller. So I didn't need her and broke my heart. I had an RN that I worked with for like 12 years who is also phenomenal. And she came over with us. And then after a little while, we both realized like she wasn't being challenged and she wasn't being used in the way she could be because she was so good. And so we both realized like she was like, I need to move on. And she did. And we're still friends. But I missed those two people. But you don't need 12 staff. You don't need 6 phone lines. There's so much crap that you can trim off your overhead. That's absolutely amazing. You can get your malpractice at like a fraction of the cost. Well, I am, but I'm also part-time.
And I think that when we actually look at what do we need to function, what do we need on opening day? I mean, you see people who are doing telemedicine only, then doing in-person visits later. You see people who are doing a lot less urgent care shifts or whatever, because their overhead is not going to need to cover certain things like you're mentioning. Now, when you look at when you opened your DPC, what are some of the things that you needed that you didn't have in fee for service that you needed to make your DPC function the way you wanted it to?
I'm going to answer all the questions differently than you think I'm going to answer them. You need boundaries. I needed boundaries because you're so like, I want people to join. I'll do anything. I'm desperate. Like, I'll come to your house at 4 a.m, So what do I always say? You under promise and over deliver. You don't offer like, I'm open Saturdays and Sundays. And like, don't do that in the beginning because then you're committed forever. So under promise, over deliver. So boundaries with patience. I will always push that. Dulcie and I are both the same way with that.
It's so good though. And it's really something that when you realize that, if you're doing DPC, this is your practice. And so you get to call those shots. That's why like one of my favorite visual representations of DPC is, the sticker on the front door that says hours by appointment only. It's the best.
Yes, exactly.
Now, you mentioned that you're a part-time DPC. So what does that mean in terms of what's your day-to-day? What days of the week do you choose to work with your patients?
Oh, okay. So I'm in the office seeing patients Monday, Tuesday, Thursday, and Friday mornings. And then Wednesdays, I'm totally off. And Friday afternoons, I'm off. And then in the afternoons, we're doing mostly telehealth, especially since COVID. It seems to work really well. So we work smart, not hard. We pack our mornings in, pack meaning, like 6 people. but we do it that way. So I can be home a lot. And in the beginning, when I was going part-time, I felt like super guilty because I wasn't working 100 hours a week. I was like, I should be working more. And my husband was like, but why? Like, you've worked so hard and you're doing a good job. So why? I'm like, because. So I finally learned to let that go. And I got to give a shout out to Amy Walsh, because one day when I saw her at a meeting or something, she was like, dude, how are you doing this? What do I do? And now Amy Walsh spends like her summers at her lake house, like a lot. So she's doing it too. And I'm so proud of her. So it's great.
It's interesting that, when your husband is saying why, like in your brain and in your training, you had done over 12 years of that. And then like to change that habit, I mean, habit changing is hard. We all know that, but especially when professionally, we only really know one way, leaving residency and the fee-for-service world that we're trained in. So it is really challenging, especially when we're realizing that we might be getting into fee-for-service type habits again. And then we realize we don't have to. So when you talk about, mentoring and talking with each other, it is so important, because we all, I feel, have that shared, these are the bad habits that were instilled in us when we trained. Yeah,
totally. And I have to put a qualifier in here. Like, I think about you and I think about Vance, and you guys are all in, and you're badasses and you do everything. And so I have to say to all these people, all these listeners, I live in Denver. I live in the city. I know a ton of specialists. We have 24-hour, like, everything can be gotten in the city without me. So I know that my patients are well cared for. Even if I'm not around, they're well cared for, because I have a PA, I live in a big city. So not everybody can do part-time, and not everybody can do this practice, and not everybody wants to do this practice. So I'm only speaking to those people, because I don't know that at Big Trees you could actually do part-time. Maybe you can. Yeah, I mean, I probably could. It'd just be different than Denver.
Yeah. And that's the thing, it's like Garrison Bliss says, if you've seen one DPC, you've seen one DPC. And so, yeah, I think that especially the finding somebody who you can relate to, whose schedule you want to emulate, or whose ideal practice is exactly what you're wanting to build, or whose actual practice is what you're wanting to build towards. Keeping in contact with those people can really make a difference in terms of building out and sticking to your plan, your business plan, your dream plan, whatever it is. And I would say it also depends on how financially you might have set up your business model too. Those are things to look at. If you want to build a practice a particular way, just like how you talked about how Pam Weibel was the heart and Dave Chase's words were the brain. It's like you have your financial part of your DPC, you have your relationship-based practice. And so finding a place where they work together to still work towards your dream, it absolutely is possible.
Amen, sister.
Yeah. Awesome. So now, who was with you staff-wise on opening day?
Oh, yeah. So I had Melissa as my PA, and I got married to my husband in March of 2000. And then I started working with Melissa in fee-for-service in September of 2000. So we've been like work married to each other for as long as we've been married to our husbands. So she was with me, and I had a person who did front desk. Her name's Chelsea, but her husband was stationed first in San Diego and then in Hawaii. So she was like my virtual front desk person. Chris, my front desk from my fee-for-service, also came over with us. She had joined in 2011, our staff. And so she'd only been there like a year when I made the jump to DPC. So she was very brave and trusting to do so. And then my nurse.
And when you were transitioning over from fee-for-service to a completely different pay structure model, how did you set your pricing?
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad.
Oh, so it started at the 4 a.m. kitchen table, and I was just throwing out random numbers on a paper. And then it ended in a California pizza kitchen with my husband on a napkin. So Ryan Newhofel, he was in a college town, and his prices back then were so low. And I was like, honey, I think these prices are too low. And so we set them higher. And then Ryan wasn't growing very fast in the beginning. I'm going to out his story. And so then he raised his prices, and suddenly he grew like wildfire. So it's there's such a thing as not charging enough, and people thinking well, why is this so cheap? Who is this person? So that's how my fees started, is randomly on a napkin.
That is awesome. I hope you framed that, because I totally have my Santa Cruz DPC brochure that I didn't have any. So I didn't have any scratch paper when I was talking to Dr. Janine Rodoms out in Santa Cruz at Santa Cruz DPC. And so she handed me a brochure from her clinic, and I still have it to this day. And I was like, oh, this is where she told me to, talk to James and Emily at Halcyon.
Yeah.
And yeah, so I totally those are my mementos of remember when remember when you were so excited and you learned about this. So yeah, I hope you frame that. Because those are your beautiful brain, all of our beautiful brains able to just be free and to be able to plan and dream in the manifestation of, writing on napkins or wherever it is. So that's awesome.
We'll put them in the DPC museum somewhere.
That's amazing. Oh man. So when you were, after you had staff join you, and then you set your pricing and you opened, how did you train your staff? Because yes, you guys had worked together, but now you're working together under the umbrella of DPC. So talking to the patients is different, having them understand the model, as well as them being able to explain the model to potential patients joining your practice. How did you train your staff and train the clinic to have a culture that favored DPC?
Oh my gosh. Yeah. It was like speaking a new language. And so we had to, what helped, because back then nobody knew what it was. So what helped is we had these almost like seminars for our existing patients who were in fee-for-service to come and learn about DPC. And so that's how I kind of perfected my communication of what it was. I would tell them. And then slowly but surely, our staff, they would also learn the language of DPC and learn what to say and how to say it. And so we all learned the 6 months before we were going to make the jump to teach the patients. We learned the language. And so my staff's amazing. They were all in from the beginning. And so when we opened, they sell the model. Chris and Chelsea, they know they work at the front desk. They do the blood draws, they do the labs, they do the triage. They know how to sell it just because of the way they learned how to speak it. So you have to learn how to speak it first. So it was so fun because we were learning together, and we were really busy, but it was all a different energy. We were excited. We were busy in a different way. We were busy growing and marketing and, learning how to do things by the seat of our pants. And it was so much fun.
When you were talking to your patients in person, when you had those, seminar meetings, did you find any other marketing strategies that worked? And did patients really understand DPC because they already had you as their doctor and they understood the value proposition of maintaining that relationship? Or did they really not get DPC?
Oh my gosh. And I'm sure everybody goes through this still to this day, but they did not get it. They didn't get it. Like I would explain it and they would just come back to me and go, but I have insurance. Like, I know, I just explained how it works with insurance. And then we had one of the meetings, we had this really funny patient. She was there and all these patients were confused and listening. And I felt like I paid her to be there, but I didn't. Like she was a plant because she was like, so what you're saying is for the price of like a nice dinner for my husband and me a month, we can get all access medical care. I was like, yes, that's exactly what I'm saying. So no, it was like pulling teeth. And I like to call it like the lean back, sit straight, lean forward, because as people start to understand it, and that goes for not just patients, but like anyone you talk to about it, like specialists, administrators at the hospital, they're leaning back in their chair and they're like skeptical and their arms are crossed. They'll have their hands crossed, like, and they'll be leaning back in their chair. And then they kind of start understanding. So they sit up straight. And by the end, they're like leaning forward towards you, like, tell me more. It was so funny. It happened all the time. Has that ever happened to you? Have you paid attention to that?
So it's funny because I would do initial meet and greets on Zoom. And so it would be so interesting because one, doing Zoom was actually a screener for me to be like, how is tech feeling for you as a patient? Because my practice is definitely like maximizing tech and then seeing a patient in person if needed. And so I would say a quarter of the time, the people I was doing meet and greets would have a black screen because they weren't necessarily using Zoom with the video on or whatever the issue was.
Yeah.
And then in terms of, I had been really surprised. Some people, they just understood that in our area where there's very little access to care, they're like, whatever it is, I can't lose you as my doctor. And then I had other patients who were like, yes, I love that analogy of the like crossing the arms, lean in, lean out, lean in, and the like going back and forth, because I remember some of the conversations my previous patients from my former fee-for-service practice, they said those words, but I have insurance. And ironically, maybe a couple of weeks ago, I had a patient who's been with me since early on ask me in a portal message, can you just bill my insurance? How come I'm paying out of pocket? So that culture in us to use our, as Jeff Gold puts it, to swipe our insurance cards like credit cards is really, really ingrained because, patients sometimes forget that they have access to us through whatever means they do. Patients see their loved ones using their insurance cards and then they forget that like, oh yeah, I'm actually doing this separate model. So I see the gamut of differences in getting it, so to speak, getting the DPC model. What you're saying, I can totally relate to it. So yeah.
That's so funny. I was so overconfident that everybody would understand it and like they'd be beating down our door. And I quickly learned that wasn't the case because I think we had like, I don't even remember some number of thousands of patients. And I was like, oh my God, we're going to be full right away. And then we only had like 200 people join right off the bat. So then once we opened, I did marketing and I did sports physicals for the local high school. And we had like ads in the newspaper. We were doing Facebook a little bit, but mind you, this was 2012. So we were doing some old school stuff. So we didn't have to do too much marketing because word of mouth just took off and our little neighborhood didn't have a ton of primary cares. So it was pretty easy, thankfully.
Let me ask you here, the 200 patients who joined, which is amazing. Like, even though, it's a small portion, it definitely allows you to have a member base, to have the income coming in. But I want to ask, who were the patients who found the value proposition of having you as a doctor, having, the DPC as a model? Who were the people who valued that and joined your practice, and have most of those people stayed today?
Okay. So that's so interesting because I was thinking about it. And yes, the early adopters are still with me now. Like, it's so crazy. So many of them. So they've been my patients now for like 20 years. I mean, it's like I have a couple of patients that I took care of in residency clinic and they're still my patients. One of them just moved to the South and my heart is broken and I'm definitely going to go visit her. But a lot of them, yes, are still with me. Their family has come and joined, like their brothers or sisters or husbands or whatever. And one of I think it was the first person that signed up, like physically signed up. It was like a year went by in DPC in 2012, and he hadn't come in a single time. So I think I called him and I was like, hey, buddy, like you were the first person to join my new practice, but you haven't even come in for like a physical. Like, do you not want to like spend some time with me since you're paying me? And it was so funny because he was like, I don't know, maybe 40. And he said, I don't need anything right now, but I know I will at some point. So when I need you, I need you. And I was like, oh, okay. So then fast forward to like 2 years ago, and he gets prostate cancer and he's doing great. But it's so funny because he remembered that conversation that he and I had, 10 years ago. He said, remember when you called me because I wasn't using you? And he said, I told you this would happen. And I was just like, oh my God, mind blown. I love it. It was so funny. So it's amazing who joins and who doesn't join. And then who didn't join initially, but then 6 months later, calls saying, please, can I join? Because I realized what care there is out there in fee for service. Oh man. So that was pretty fun.
Yeah. And how relieved I'm assuming he must have been to not have to question, well, how long does it take for me to get into my doctor to discuss this? Because we've all seen so much piecemeal care, especially when it comes to really, concerning diagnoses like that, cancerous type diagnoses where, I got diagnosed with this on my mammogram and it's going to take, how many weeks to get in to see, XYZ. And we have the ability as relationship-based doctors to, okay, I get that you can't see potentially your fee-for-service doctor, but I can call on your behalf to talk to an oncologist in that cancer example, to start getting, your workup going or images ordered, figure out, can we, do a cash pay order for this image that you might need rather than waiting for your insurance to cover it, whatever it is, so that your care is not delayed any more than it needs to be because of the fee-for-service model. So I think that is awesome. And I'm sure that there are multiple patients out there who can relate to that experience of, when I need my doctor, I actually do need my doctor. And that's what DPC is built perfectly for.
Oh my God. Yes, exactly. It's all about the relationship. And another perfect example of that is I love meeting specialists. So because, I'm social and all, I like to go out and have like a cocktail with a specialist or something or coffee. So I met serendipitously, I met a breast specialist who's new to my area earlier in the spring. And we got along great. And nowadays it's so great because we have everybody's cell phones. And so literally like 2 weeks after I met her, one of my patients came back with a suspicious mammogram. They did the biopsy. It was malignant. So I texted her, this breast specialist I just met. She got this patient in the next day and did her surgery the day after that. So it was literally 2 days from her biopsy result until she had her surgery. And if I didn't have that relationship, like she wouldn't have gotten that. And if she was in fee for service, she wouldn't have gotten that. So I was like, that's amazing. It was 2 days. Like, come on.
That's incredible. And that's why I still call my old attendings from residency, because it's like, they know who I am. And so if I'm calling them with like, hey, I really need this person to get in, I love that, like you're saying, that relationship, they will make changes in their schedules, adjust what they can so that the patient can get seen. Like it's like, I get that DPC is not for everybody. A huge reason this podcast exists is to put it out there as an option for people to consider, no matter if you're in fee for service or in DPC. At the core of why we are physicians goes back to wanting to take care of our patients. This idea that we take our Hippocratic oath and the idea of do no harm. We are really looking out for patients at the core of everything we do. But when it comes to then taking that desire to help a patient and putting that desire into particular models, fee for service or DPC, the outcomes are different. But I will say that when you show as a DPC doctor, especially that, hey, you're involved in your patient's care, even if they're seeing a specialist in fee for service, it really can make a difference in terms of their outcomes when they see like, oh, like this person isn't just being referred, they actually have a whole story and a whole support system medically behind them. It makes even specialists think about care differently. And so I've seen mountains move, just like your patient with the breast surgeon. I've seen those examples happen even more so in DPC, because we have the time as physicians to then call the specialists and connect with them and say, hey, this is exactly why I'm needing this patient to get care sooner than later. So I absolutely love that.
Exactly. I love it. And I have to tell you a flip flop of something that caught me by surprise. I was doing a talk the other day at one of the hospitals here to like the medical executive staff. And I was talking about DPC as a model. And one of the specialists like raised their hand during the talk and was like, well, your patients are sort of being groomed to expect a higher level of care, so that when they get to us and we're busy, we can't really give them that level of care that they have been taught to expect from you. And she said that, and I was like, did you hear what you just said? And I don't know how many people listen to this. Maybe I don't. She was an oncologist. So I was like, oh my God, like you just said that. And you're an oncologist and you're worried that I'm spending too much time and giving too good of care to my patients. That's what you just said. And I was very gracious about it, but I was turning that in my head on the way home. And I was like, I can't believe that just like she was judging me for taking good care of my patients and spending time with them.
Wow. Yeah, that is an absolute opposite example of relationship-based care. So, and it's scary because especially dealing with a diagnosis of cancer or end of life type of diagnosis, to have the support is insanely important at that time, especially. So with your practice being so successful, and how you mentioned the original patients who joined, a lot of them are still with you. How has churn been for your practice over time? Because I think about what are the reasons that patients have left. Like you said, your sweet patient moved to the South. What are the other reasons that you see people churning in your DPC?
Most of them are that they move. The other ones, a little bit during COVID, because we enforced CDC recommendations, some of them got frustrated and didn't agree. So they chose to leave. I have some other patients that I'm really somebody who likes to empower patients and make sure that they take accountability. So if they're asking me like to fill out FMLA because they hate their job and they tell me, I hate my job, will you give me FMLA? Like, I'm going to be really honest with them and say, I'm not going to do that. How is that going to help you advance in your life if I bail you out and give you a parachute just because you don't like your job? What do you think you should do instead? Well, I should probably find another job. And I'm like, I'm not going to, there's no but here. So I'm pretty strict on that stuff. And if people don't like that, then either I tell them that it's not an optimal relationship, or they choose to find somebody different. And so that's part of shaping your practice. And you all need to swallow your pride. If somebody quits your practice because they don't like your shirt, it doesn't matter. Like, don't dwell on it. Don't take it as an insult. Don't be pissed off. Like, let them go. It's okay. And you're going to shape your practice and draw in the patients that you draw in the patients with the energy that you give. So if you hate your practice or you hate your patients, look at what you're doing and what you're putting out there, because it's not the patients. It's usually you and what you're doing. Hard truth there.
Yes, if you're feeling stressed and your patients are giving you that feedback, or that there's not a good fit for patients who are joining, stop and reflect on what is the situation going on. And now on your website, you have our practice and waitlist are full. And when you try to click on the button, it doesn't click anywhere. Do you still have people contacting you? And what do you do with those people? Do you, say, hey, here's a list of DPC doctors in the Denver area? How do you handle contacts who might be interested in DPC but are not going to be a good fit for your practice?
Yeah, that's a tough one. It's so funny also because we started our waitlist a long time ago, and as soon as we went on waitlist, and I think a lot of people across the country realize this, when you have a waitlist, suddenly it's like you're the Ivy restaurant in Beverly Hills. Like, everybody wants to be in your practice now because you have a waitlist. So it's funny from a marketing perspective. Even if you're not full, you might try and put a waitlist on your website and see what happens. But now we're like our waitlist is, it was, I don't know, it was like approaching 200. It was just bad. So we were like, we can't. So we turned it off. So it's really hard because everybody will, like, oh, I've been your patient for 20 years. Or a doctor will call and say, oh, will you please take my friend? Or, like, do me this favor. And it's easy to try and play favorites, but it's really not fair. So I tell people, like, I am like the most diplomatic person. I am sticking to my wait list. I can't play like favorites. So I just have to be really clear with that. And it's frustrating, but we do have amazing DPC doctors around town. So we have the ability in Denver, thank God, to refer to each other. However, they're all getting full too. So if anyone wants to open up a DPC in Denver, come on out, because we have plenty of patients to go around.
And plenty of support, in terms of, we'll get into how you're able to continue living life the way you want to after you open your DPC, like taking trips when you need to, taking time for, yourself whenever you need to. But I want to ask before we go there, in terms of your wait list, how do you keep in contact with the people on your wait list to give them, an update as to where the practice is in terms of accepting people, or how do you keep them involved so that they still know, what's going on in the practice if you guys have new features coming down the pipeline or whatnot, as they're, sitting on this potentially perpetual wait list?
You're totally pinning me down, because we haven't been reaching out to them. And oftentimes they'll reach out to us and say, like, am I moving on the wait list? And we're always, our staff is so nice. And we're always like, you're here, or whatever number you are. And we're really sorry. It's still, such a long wait list.
The reason I asked that too is, especially the part about referring to other DPCs, is that Dr. Erica Young in White Marsh Island, Georgia, she had said, I'm full, but there's a pediatrics DPC right across the parking lot from me. You can go there, wherever. But I think that if a DPC is similar to you and that there are other DPCs opening, and you guys are geographically close or whatnot, collaboration in terms of, hey, I'm not accepting, but here's the link to, Johnny Appleseed DPC or whatever it is, and they're accepting patients. That's one strategy that could be used to collaborate within a community so that more patients are coming over to DPC, and that word of mouth is spreading for the whole community. So just one way, the one thing that I think about when I hear what you say, and then also think about what Dr. Young is doing down in Georgia. But yeah.
And that's a great idea. On my website, I can put links to my colleagues. You are right. Totally going to do that.
Yeah. Absolutely. And that goes back to why I love DIY websites, because you can just change those links anytime you want. So that's amazing. Yeah. So since being a DPC doctor, I want to ask about your coverage for your practice, because you've been able to go to New Zealand and do some bungee jumping, and you've been traveling as you wish to travel. And like you talked about your parents, as you wish to live your life because of what you learned from their experience. But how are you doing it when you need coverage, whether a patient needs to be seen in person, or if a virtual visit is okay to cover their care?
Yes, it's actually worked out amazingly well because of Melissa, my PA. We cover for each other when we're both, like, when we're on vacation. Like, she's going to go to Italy in October, and so it's easy that way. And then on top of that, I have like Michael Keller and Derek Wachaban and Bree Seefeld. So the other DPCs in our area, I can just text one of them and say, can you cover if Melissa's not available? And we usually end up covering most of their patients through telehealth. We cover for each other, or they cover my patients through telehealth. It's worked out very, very well in the last 10 years. Like, it's been pretty smooth. And we don't have any financial arrangements. We just help each other out. And it's actually felt normal and great. And it's pretty easy. Like, a couple of them use Elation, so they can just send me charts. Like, their staff will be working when they're on vacation, and they'll send me charts so I can see their patients if I need to. And I have a login of my own to Elation, but I can have their charts. And then, so it's like the support staff actually helps make call easier, because the support staff in all the offices is still there answering phones. I always tell my patients when I'm going out of the country. So the volume of requests definitely goes down while I'm gone. And that helps too. That helps the burden of the practice.
And to clarify, say somebody's on a different EMR and you're like, oh, I'm doctoring for this patient over telemedicine, but I'm not sure like your allergies or whatever. Are you just relying on the office staff to really be able to get you the paperwork or the history that you might need? Like they'll fax over whatever you need electronically or something like that so that you have the components to make the medical decisions you need to make at the time?
Yeah, that's what we do with the support staff. They're super helpful. And I'm sure, I know the tech savviness of you, you'd probably figure out something even better than that. But thank God for good support staff. Yeah.
That's awesome. And, it's something to talk about. Like if you're wanting coverage, that is another type of boundary for your practice, but you can absolutely encompass your community in that boundary. So like, for example, in California, we have this DPC California Syndicate. That's our DPC California Alliance type of group. And we've been talking about how do we share calls via telemedicine if needed, if, a family wants to go out of the country or if a DPC doctor wants to just not have to take calls for whatever reason, how do we set that up? So you guys have just worked it out, but thinking about like, are there people that are in your community that are going to do that? Do you want to figure out some kind of way to make sure that the tech integrates or that the workflow integrates to be able to cover? How do you compensate if somebody wants to be paid financially? So thinking about those things to set those boundaries up to protect your vacation time or time that you might need away in an emergency, those are definitely boundaries. And then on the patient side of things, when you talk about boundaries, saying something like, when I'm gone, care will be exclusively delivered through telemedicine is a way to set up those expectations also, because then, a patient knows like, okay, like if I have a brown recluse bite or something that I need actual physical care for, that I'm not going to be relying on my doctor who's in Italy or whatever, I'm going to go to the urgent care. So they have those expectations built in as well.
Yeah, it's all about planning on the front end. It's totally great. And I love that the syndicate is talking about that because Denver, we're unique because we're just sort of organic. Like we organically did this with ourselves, but that's not practical for a lot of people. So making a plan and making like some sort of contract makes a lot of sense probably. So good job on the syndicate.
That was Dr. Fiedler's idea in the Bay Area. So yeah, definitely.
Oh, awesome.
Yeah. And in terms of coverage, you also have, and this is something that I've always found interesting about your website, you also have a link for aftercare hours to particular insurance companies. So like the nurse on call for Blue Cross Blue Shield or whoever the company is. And so can you share with the audience your thoughts in putting those links on your page and how have patients used those resources?
Oh, that's a great question. Well, because I'm so old now and I practiced like before EMRs and before like Google was barely a thing. Call used to be really important in primary care. When I delivered babies, call was incredibly important, of course. Like you had to be on call all the time. But it's 2022. Like people look up more medical crap online than they should be doing. So I figure, why don't I give them at least some good links to go by? And then we have this amazing thing called Dispatch Health in Denver where they will do house calls. And I think I'm going to get in trouble if I quote the flat rate, but I swear if it's self-pay, I swear it's like $250. So like that avoids an ER visit. It was incredibly helpful during COVID. They are like our call, like they can take after hours care and give after hours home care for our patients. They also do bill insurance for people who have insurance. So people are smart. And if you train them to, like I said, be empowered, they can answer a lot of their own questions without having to page you on call. And again, I'm in Denver. We have a hospital on every block. We have urgent cares more than we have Starbucks. And so if primary care on call, think of one thing that I could help somebody with after hours in the middle of this city that they couldn't wait till morning for, or if it's chest pain, why are you calling me and not going straight to the ER anyway? I know some people will totally disagree with me. And I know I see you thinking about trying to think of one that would come up, but they can still call me. I mean, they can still like email my portal. Like I love my portal. So
yeah, I love though that you have this idea of empowering your patients and your website reflects that.
So one of my patients, like this was quite a while ago when we first started DPC, she paged me at like 1 a.m. on a Saturday because she needed her estrogen refill. And it's because she's a nurse at the VA and she works nights. So she was like, well, I'm awake. I'm just going to, but she paged me. And so I called her the next day. I'm like, dude, what are you doing? Like, why did you woke me up? And she's like, oh my God, I'm so sorry. I don't know why I did that. I was awake and so then we're fine. Like I called her out and we laughed and we're fine. And she hasn't done that ever again. So it's just like, come on, but if you have 3,000 patients, you can't say, dude, what are you thinking?
Not at all. And with 3,000 patients or more, especially in fee for service, it's really, I mean, they would hardly even get to talk to you because it's usually like the layers of admin before they even get to talk with you. So yeah, that's cool though, that you were able to do that and just reset the expectations and those boundaries on a personalized level. In terms of other features of your practice, you offer immigration physicals. And so can you share about how you got involved in that and how that works into your practice separate from your regular DPC members?
Yeah, it's actually really cool. We've been doing those for, 20 years. So people to immigrate to Canada, Australia, New Zealand have to have this panel physician's office do their immigration physical. And it is like silly paperwork to move to those countries. And so my PA has been like the expert of doing those since I graduated residency. So we were doing them at the old practice and they just moved with us, these immigration physicals. And so it's a cash-based like side hustle in a way, I could say. But the cool thing is that it helps us give scholarships to our underserved patients. So we funnel that money to these underserved patients and we can give scholarships to them. So it's actually it's fantastic. It's easy work, it's fun, and it went way down during the pandemic, obviously. So that income source almost disappeared. That was a challenge, but we got through it. So, but I just love that we can actually do the scholarship program with it.
That's so cool. And in terms of affiliations, you have affiliations with the Presbyterian St. Luke's Medical Center and Rose Medical Center, and then the Rocky Mountain Hospital for Children. What are your affiliations, and do you round on patients if they were to be admitted at those locations?
Oh, good question. So I did my residency at Rose, and it's a spinoff of university. So I don't have hospitalist privileges, but I do go see my patients. What are they called? Social rounds. I do social rounds at the hospitals. And then I'm on faculty for University of Colorado, teaching staff. That's how I met Allison Edwards. Actually, I think it was through, she came and did a rotation with me when she was thinking about DPC as a resident.
Awesome.
And then, PSL, I'm the department head of family medicine for Presbyterian St. Luke's. So I get to go to the meetings and kind of listen to the dark side, but no, they're actually really nice. And it's nice to be connected to the hospital just to know what's going on and have updates about the community.
And absolutely the community focused presence, as well as the ability to hear what's going on, to have your finger on the pulse of the community, especially when you say there's more, hospitals than Starbucks in your area. So absolutely.
Yeah.
And in terms of going into the future, one of the things that you've been so passionate about is really helping people be confident and understand the DPC movement as a whole, and being an advocate for the movement as a whole as well. So how do you see DPC growing into the future?
I've already been so impressed with how quickly it's grown from nothing to people know what it is. And so the thing that I want to just implore all of the doctors that are doing DPC and all of you that are thinking about it, once you eventually do it, because just do it. You have to help those on the rungs of the ladder below you. You have to help them, reach out your hand. I had so much support from those few people like Sharon and Ryan. When I first started, I had so much support from them and they didn't ask for anything. And I don't think any of us should ask for anything when we're helping our peers. Pick a few people to mentor or do some public speaking or do something to help out this movement, because this movement will save your life and you owe it to this movement to save its life and to make it grow. You're not in this for the money. If you're in this for the money, okay, fine. But if you're in this because you love being a doctor and you love having a personal life and you love traveling all over the world like I do, you have to keep this movement alive and it's your responsibility. So please take somebody under your wing.
Amazing. Thank you so much, Dr. Davidson, for joining us today.
That was so much fun. And thank you for being in Denver. It's been a blast.
Next week, look forward to hearing from Dr. Kristen Dahl-Winther of Birchwood Family Medicine in Birchwood, Wisconsin. If you've enjoyed the podcast and you haven't yet done so, subscribe today and share the episode with a physician you may know who needs to hear about DPC. Leave a 5-star review on Apple Podcasts and on Spotify now as well, as it helps others to find all these DPC stories. Lastly, be sure to follow us on social media. If you're wanting to continue learning more about DPC in the meantime, check out dpcnews.com. Until next week, this is Marielle Concepcion.